Ladies and gentlemen, let's swiftly move on to the next segment. But prior to that, just a small announcement. We have a winner for the first competition, which was given online, and the name will be appearing on the screen. So congratulations, Ashika Pullattu Pushpakumar. So you are the first winner. So you can collect your gift from the Sri Lanka College of Cardiology office at your convenience. So congratulations. So moving on to our next plenary, that's on NOACS. Could I invite the moderators for the plenary, please? Dr. Mervyn Fernando, Senior Consultant Cardiologist, Dr. Disna Amaratunga, Consultant Cardiologist, and Dr. M.H.M. Zaki, Consultant Cardiologist, to take the stage, please. Thank you.
Good morning. We are going to start the plenary on novel oral anticoagulants. Let me introduce our eminent speaker today. He is Professor Gregory Weichlip, and he is the Price Evans Chair of Cardiovascular Medicine at the University of Liverpool, United Kingdom. And he's the Director, Liverpool Centre for Cardiovascular Sciences. And he's a distinguished professor at Aalborg University, Denmark. And he's also a member of Writing Committee for American College of Chest Physicians and Antithrombotic Therapy Guideline for Atrial Fibrillation, European Society of Cardiology. And he's the chair of the new 2018 ACCP Guidelines on Antithrombotic Therapy for AF. So it's a great honor to have you here today, sir, and over to you.
Thank you very much for the very kind invitation, and delighted to join all of you virtually today for this presentation. So my remit was to give an update on oral anticoagulation, and I'm going to focus particularly on stroke prevention in atrial fibrillation. So before I start my main lecture, just to say that I have declarations of interest. I'm not going to read every line, but put into context everything I say or speak in this presentation with regard to these declarations. Also, before I start my lecture, I'm just to say that we have some very nice friends and collaborations going on with Sri Lanka. And this is the National Institute for Health Research, Global Health Research Group on atrial fibrillation management, where we're looking at patient management focus on pathways, on streamlining management, improving management of atrial fibrillation. And as you can see, we have a team from Sri Lanka in Jaffna province and very much collaborating with us. And we are certainly enjoying this research collaboration together with colleagues in Sri Lanka. Now, in terms of managing atrial fibrillation and stroke prevention, let's start off by taking a few steps back. Because if you look at any textbooks over the last decade, or if you look at any guidelines over the last decade, and you go to the chapter on atrial fibrillation, it covers these points: stroke prevention. It covers management of symptoms and discusses rate control and rhythm control of patients with atrial fibrillation. It also covers the fact that many of our AF patients are elderly with multiple comorbidities and cardiovascular risk factors, and it requests that we try and manage these patients. So in the real world, when we manage these patients with atrial fibrillation, we need simple and practical decision-making processes, the so-called patient pathway, the so-called patient journey, and the steps of managing patients in a holistic manner. Now, some of you may be aware about the recent European Society of Cardiology guidelines, which were presented and published just a couple of months ago. And it takes this approach, it's a very patient-centered approach, and it can be summed up as CC to ABC. Well, what is this CC to ABC? Well, the CC, confirm atrial fibrillation, because even before you start the management or the patient journey of atrial fibrillation, you have to confirm the diagnosis. And this refers to obviously whether with ECGs or other modalities to confirm atrial fibrillation. Characterize atrial fibrillation, and of course that's what we do as cardiologists. We evaluate the patient, we assess, and this is the 4S scheme. S for stroke severity, and we have the CHA2DS2-VASc score for that. Symptom severity, we have the ERA symptom score to assess patients with atrial fibrillation. Severity of the AF burden, and this refers to paroxysmal atrial fibrillation, arrhythmia burden, etc. And of course, lastly, substrate severity, and this reflecting what I mentioned before with regard to the comorbidities and lifestyle type factors associated with atrial fibrillation. So that's the CC. Then you go on to ABC, which is treat atrial fibrillation. And let's make atrial fibrillation management simple, because it's simple as ABC. A is avoid stroke, or A is anticoagulation, where the default is offer anticoagulation unless they're low risk, and I'll come back to that for the main component of my lecture. B is better symptom management, referring to patient-centered and symptom-directed decisions on rate or rhythm control. And the C is comorbidities and cardiovascular risk factor optimization, and addressing all the risk factors associated with atrial fibrillation. So for the purpose of my talk and oral anticoagulation in the NOACS, I'm going to focus on the A, and that's essentially stroke prevention. So I stated before, keep this simple. The default is stroke prevention unless they're low risk. And stroke prevention means managing oral anticoagulation, whether with well-managed warfarin, is not simply writing a prescription for warfarin and forgetting about it. Pay attention to the quality of anticoagulant control, and that's the TTR, time in therapeutic range, and I'll come back to this. Or these days, increasingly, a NOAC, a non-vitamin K antagonist oral anticoagulant, sometimes referred to as a DOAC, direct oral anticoagulant. And that's what the new ESC guidelines tries to emphasize, because as you can see, the treatment algorithm is summarized here. And if the patient, of course, has severe mitral stenosis or prosthetic mechanical heart valves, we have to use warfarin with a good TTR, time in therapeutic range. But in the what was previously referred to as non-valvular atrial fibrillation, or basically atrial fibrillation without significant valvular heart disease, which is the new terminology, the first step is to initially identify the low-risk patients. Low risk is those with a CHA2DS2-VASc score of 0 in males or 1 in females, no antithrombotic therapy. Step 2 is anticoagulation to those with 1 or more stroke risk factors. The strength of the evidence differs, reflecting the level of evidence, because most of the clinical trials include patients with 2 or more stroke risk factors, so it gets a class 1A recommendation. Those with a single stroke risk factor, it is subsets of some of the larger trials or a whole host of real-world data, it gets a class 2A recommendation. Step 3 is offering anticoagulation, and the ESC guidelines, as in most of the guidelines internationally, a preference is for the NOACS as initial anticoagulant therapy for stroke prevention in atrial fibrillation. But I just want to very briefly mention that we may well be talking about NOACS for the rest of this lecture, but warfarin has been around for a good 5 decades. And if you handle warfarin well, patients actually do quite well. But as I made the point, it's not simply writing a prescription for warfarin and then just ignoring your patient, because how warfarin performs depends so much on the quality of anticoagulant control. And for stroke prevention atrial fibrillation, we should be aiming for an INR of 2 to 3. And for the TTR, time in therapeutic range, it's pretty obvious. If the TTR is 70–80%, you see the risk of stroke and the risk of bleeding is very low. If the TTR is 40–50%, you see the risk of stroke and bleeding is high. So if it's well-managed warfarin, the patients actually do very well. And the challenge, however, is how you can manage the patient to get a good TTR. Now, the landscape for stroke prevention in atrial fibrillation has changed markedly in the last decade by the availability of the NOACS. And the NOACS are supported by well-conducted randomized trials. This is a meta-analysis of the phase 3 pivotal trials, the 4 pivotal trials for NOACS versus warfarin. And the principal efficacy outcome is stroke systemic embolism, and you can see the NOACS perform similar, or in a case of dabigatran 150 in the RELY trial and apixaban in the Aristotle trial, superior to warfarin for preventing stroke systemic embolism. You do a meta-analysis, that's a 19% advantage in favor of the NOACS compared to warfarin. What about for major bleeding? The NOACS perform similar, or in the case of apixaban in Aristotle and the edoxaban in the ENGAGE trial, safer than warfarin. Overall, with the meta-analysis, you see a 14% advantage, less major bleeding in the patients on the NOAC compared to warfarin. But the secondary outcomes are also important. Look at hemorrhagic stroke, intracranial hemorrhage, about 50% less in favor of the NOACS. If you turn the clock back for warfarin versus placebo in the historical trials of 2 or 3 decades ago, warfarin compared to placebo, reduced stroke by 64%, but it also reduced all-cause mortality by 26%. You will see here that the NOACS now, compared to warfarin, an additional 10% reduction in all-cause mortality. So these are the randomized trials. They are specific inclusion and specific exclusion criteria. And the drug is then made available. And you will also should be made aware that in the phase 3 trials, the Asian population is you could say underrepresented, because the majority came from many of the Western countries. Well, we have a lot of data how the drugs perform in real world clinical practice, particularly from Asia. And I'll give you some examples. This is from the Korean National Registry, so Asian patients. And as you can see, how did NOACS as a class perform? NOACS in red, warfarin in pink. Ischemic stroke performing about the same, but look at the better safety. Intracranial hemorrhage, look at all-cause mortality, significantly lower on NOAC patients compared to warfarin. Look at the composite outcome, stroke, intracranial hemorrhage, and mortality, significantly lower in the NOAC patients compared to warfarin. And this has a great impact on the healthcare in a country. And this is an example. This is from Taiwan. And you'll see they started a low base of anticoagulation, 2008 going on to 2015, how the anticoagulation rate was quite low before and increasing over this 15-year period. And you could argue is largely driven by the availability of the NOACS. But over this time period, look at ischemic stroke. That's the little red dots there, coming down, declining over this time. Look at mortality. That's the little purple dots there, coming down over this time period as well. And despite the increase in the anticoagulation rates, you look at intracranial hemorrhage, which is the little green triangles, remaining remarkably constant over this time. So as the impact, given that strokes are a major healthcare burden in any healthcare system, how the increase in anticoagulation translates to a reduction in ischemic stroke, also translates to a reduction in mortality related to atrial fibrillation. Now, in terms of real-world data or analysis, how the NOACS perform in everyday clinical practice, I'll start up by this study. This is from the FDA. It's a regulatory body in the United States, of course. And they conduct their own analysis, and it's looking at effectiveness and safety outcomes of the NOACS versus warfarin. And as you can see, for apixaban versus warfarin, apixaban, a factor Xa inhibitor, you see both for stroke, intracranial hemorrhage, mortality, and major bleeding significantly lower compared to warfarin. For dabigatran, and these are US data, in US only the 150 dose is licensed for stroke prevention and atrial fibrillation. You see a reduction in stroke, intracranial hemorrhage, and mortality compared to warfarin. Major bleeding was similar, and that's in keeping with what the RELY trial for dabigatran versus warfarin showed for the dabigatran 150 dose. Rivaroxaban versus warfarin, you see stroke, intracranial hemorrhage, and mortality is reduced, but actually major bleeding was higher compared to warfarin. The FDA also looked at NOAC versus NOAC comparisons. And without going into the detail, by and large, for ischemic stroke and for mortality, they perform much the same. The differences largely come when you look at the safety side, which is bleeding. So for example, if you look at dabigatran compared to apixaban, dabigatran had less intracranial bleeding, but more major bleeding. If you look at rivaroxaban versus apixaban, you see major bleeding and mortality was higher on rivaroxaban. And rivaroxaban versus dabigatran, you see intracranial bleeding, major bleeding higher in the rivaroxaban treated patients. Now that's US data, so let's turn to some Asian data. And these are from the Taiwan registries. And you will see here, this is warfarin compared to the 4 DOACs, the 4 NOACs there, as you can see. And for stroke systemic embolism, you see very consistently the 4 NOACs, they perform about the same as each other and lower than warfarin, which is the light blue line. If you look at major bleeding or you look at intracranial bleeding, I think this is pretty impressive here. You see better safety in favor of the 4 NOACs compared to warfarin, which is the blue line. And the same pattern is repeated elsewhere in Asia. This is from the Korean registries that we publish. These are comparisons versus of the NOACS versus warfarin. And if you look at ischemic stroke, intracranial bleeding, gastrointestinal bleeding, major bleeding, or the composite outcome, you see all the 4 NOACS performing better compared to warfarin in the Asian setting. Now, what about NOAC versus NOAC comparisons? Well, this is a very busy forest plot. Again, I'm not intending to read every line here, but I made the point before that for the efficacy outcome, which is, or the effectiveness outcome, which is essentially stroke, they are largely similar to each other. But when you come to safety side, there are some differences of the bigatron, apixaban, and indoxaban, lower rate of major bleeding compared to rivaroxaban. So you can see here, that's what the data tell us. And as I said, in terms of the effectiveness, they are largely similar to each other. When you come to safety, there are some subtle differences between the different NOACs. Now, I just want to point out some high-risk groups that are relevant to this discussion, because the very elderly, generally they've been neglected with regard to being treated with anticoagulants for stroke prevention in atrial fibrillation. And you'll see that the NOACs actually do show good effectiveness and safety, even in the very elderly patients. Again, more Asian data here. And when compared to warfarin, you certainly see the NOACs have better effectiveness with lower risk of ischemic stroke and also lower risk of the composite outcome. So in fact, there's no good reason why the elderly patients should be declined or should be avoided anticoagulation for stroke prevention, especially in the era now of the NOACs. Now, this is an interesting analysis because this is looking at diabetics. Now, this is highly prevalent also in South Asia. And the reason I show this, not just to flag up the differences in particularly ischemic stroke, but as you can see, in terms of comparing NOACs versus warfarin amongst diabetic patients in Asia, a reduction in major adverse cardiovascular events. There's obviously the safety that I showed before with regard to less major bleeding and less intracranial bleeding. But look here at this major adverse limb events. And remember that diabetics are high risk from the vascular point of view. Look at amputation significantly reduced. Major adverse limb events is also significantly reduced. So even the patients with high atherosclerotic burden, the NOACs confer an advantage over warfarin in reducing major adverse limb events. Now, remember that risk does not remain static, and there's a general tendency just to assess stroke risks and then completely forget about the patient. And even in the patients who are initially low risk, CHA2DS2-VASc score 0 in males or 1 in females, over time they will develop new risk factors. And on average, the 80% of the patients, in the patients who are initially low risk, after about 4 months, 4 to 6 months, on average, 80% will acquire 1 or more new risk factors. And these patients, if they acquire a risk, 1 or more risk factors in the CHA2DS2-VASc score, they derive benefit from anticoagulant therapy. And that's evident for both males and for females. So they need to be regularly reassessed for their stroke risk. Now, putting this all together, this is the CHEST guidelines. And in contrast to some of the international guidelines, the CHEST guidelines is based on systematic review and evidence appraisal. And these are not recommendations in this table, but in the CHEST guidelines, there was a table to give a simplified schema to what might be the initial anticoagulant choice. Because if you turn the clock back a decade ago when we were prescribing anticoagulations, we didn't have a choice. Today, in 2020, we are spoiled for choice because apart from warfarin, in some parts of the world, there's up to 4 NOACs available. So this table suggests the initial possible choice to consider. I'll take you through some of this. In patients at high risk of bleeding, we have the HAS-BLED score to quantify this. You might wish to consider the agent where in its respective clinical trial and real-world data was associated with less bleeding compared to warfarin. And that was seen for apixaban, the bigatron 110, and edoxaban. Now, some of the high dose NOACs are associated with higher gastrointestinal bleeding. You might choose therefore the NOAC, where in its respective clinical trial and real world data was not associated with any excess of gastrointestinal bleeding compared to warfarin that was seen for apixaban and the dabigatran 110. You may wish to shoot for potency, patients getting strokes despite being on well-managed warfarin. Therefore, you choose the NOAC where in its respective trial and clinical and real-world evidence showing that there was a reduction in both ischemic stroke and hemorrhagic stroke, and that was seen with the dabigatran 150. Now, the guidelines are there for a reason, and the message to take away is that if you follow the guidelines, and follow the label for prescribing, the outcomes are the best. And this, I'll give you two examples. This is from the Korean registries. And those who don't follow the NOACs, the patients who don't follow the NOAC prescribing, they are associated with worse clinical outcomes. You can see it pretty clear for stroke, for major bleeding, and also for mortality, particularly overdosing. You see the same pattern in other countries. This is a study from Thailand that we published. And again, the patients who are either underdosed or overdosed, they do worse compared to if you follow the label. So with regard to using the anticoagulants in clinical practice, let's try and put this all together, because we need this holistic approach to managing atrial fibrillation. And why is that? Because the patients, they present to general practitioners in primary care. They may well present to secondary care in the hospital. They may present to non-cardiologists in the emergency room, even in the cardiac ICU or the theater. They present to cardiologists. And even within the cardiology department, there's the non-arrhythmia specialist and the arrhythmia specialist. We need a simple and a streamlined, uniform approach, because at the end of the day, we have the patient who is seeing all these different healthcare professionals. They need a unified and a consistent message. So it's this so-called patient pathway and a patient journey. And the ESC guideline flags up the ABC, and the A is avoid stroke, where the default is stroke prevention unless they're low risk. B is better symptom management with rate or rhythm control, and C is cardiovascular and comorbidities, including lifestyle type changes that need to be optimized. So it's all very well having a concept. Does it work, and how can you operationalize it? Now, this is a primary care clinical pathway for atrial fibrillation detection and management. This is from the promoted with Public Health England and NHS England. And it highlights how general practitioners particularly can help with the detection of atrial fibrillation. It's got the risk scores there. And then here we have the ABC of atrial fibrillation: A, avoid stroke; B, better symptom management; and C, cardiovascular and comorbidity management. This is downloadable here. I mean, this is a free access, and actually many friends and colleagues in Eastern Europe have actually done this and translated it. And in fact, I believe there's versions of this in Bulgarian and Russian and other versions just on this atrial fibrillation detection and management on one page. Does it work? Well, the ABC pathway has been tested in cohort studies as well as in randomized trials. Let me just share with you one. This is from the Artro AF project. It's about 1,000 patients. They're all on vitamin K antagonists. And you see the patients complying with the ABC pathway do significantly better than the non-ABC compliant patients. You see about 60% reduction in the composite cardiovascular event outcome. But you might quite rightly ask me, what is more important, the A or the B or the C? And let me illustrate to you that all three are important, because the A is, this is warfarin management, TTR above 65%, doing better than those with low TTR. B, better symptom control with ERA score 1 to 2, better than those with poor symptom control. And C, those with good comorbidity management, doing better than those with poor comorbidity management. And the best outcomes is where all the ABC is followed. But of course, we need a streamlined approach. This is the MAFA program, because I mentioned before about detection and screening of atrial fibrillation. And this is this was conducted in China, the pre-MAFA, which was published as the Huawei heart study. Atrial fibrillation detected, they enter into a structured program. And this is the cluster randomized trial, the MAFA-2 trial based on the ABC pathway that we talked about. The ABC pathway has been, the MAFA trial has been published earlier this year. And looking at the composite clinical outcome of stroke, death, and hospitalization, I think it's pretty clear that the MAFA-treated patients do significantly better than the usual care patients in this prospective cluster randomized trial. And it's largely driven by the reduction in hospitalizations. And of course, hospitalizations are a major driver of healthcare costs in any country. So if you comply with the ABC pathway, the patients actually do better. This was based, and if you look at all the high-risk subgroups, do bear in mind that each of the subgroups are individually not adequately powered, but look at the point estimates, they're all virtually to the left of the vertical line, indicating benefit of the ABC pathway in all the subgroups compared to usual care. But it's worth highlighting this sub-analysis from the MAFA trial. There's often misuse of bleeding risk scores, and in the MAFA trial, we tested the Hasbled score. And the Hasbled score, of course, is the flag of the modifiable bleeding risk factors where we can mitigate those and also schedule the high-risk patients for bleeding for earlier review and follow-up. So on the left here is the MAFA intervention using the ABC pathway and the Hasbled score. And then on the right is usual care. Look at the bleeding events in the MAFA intervention, 2%. Usual care was about 4.3%. There's the perception that you use bleeding risk scores, it leads to a decline in anticoagulation. Well, in the usual care arm, you see anticoagulation use reduced from 58% to 34% at 1 year. In the MAFA intervention with the Hasbled score appropriately used, you will see that anticoagulation use increased from 63% to 70%. So you see, when tested in a prospective randomized trial, how the appropriate use of bleeding risk scores results in less bleeding and an increase in the uptake of anticoagulation treatment. So Chairman and ladies and gentlemen, let me conclude in terms of stroke prevention and atrial fibrillation and an update on anticoagulation. Well, goes without saying that stroke prevention is a priority for AF management. The NOACS have changed the landscape for stroke prevention and atrial fibrillation. We now have a number of choices and to fit the drug to the patient, but important to follow the prescribing label. We have lots of clinical practice data, so-called real-world data. They complement the randomized trial data. And the outcome data from the real-world data reflect the efficacy and safety profiles in the randomized trials. Do remember that stroke prevention and anticoagulant therapy is part of a streamlined clinical management approach. A is to avoid stroke, and where the default is stroke prevention unless they're low risk. B is better symptom management, and then C is cardiovascular and comorbidity risk optimization, including lifestyle type changes, easy as ABC. And with that, thank you for your attention.
Thank you, Professor Gregory Lip, for that very informative and comprehensive presentation on atrial fibrillation. It's great to hear from the inventor of the CHA2DS2VASc scan, Hasbled himself. So thank you so much for that wonderful presentation.
Thank you, Professor Lip, for having participated for the annual academic sessions of College of Cardiology, Sri Lanka. Because of the time constraint, we will not be able to entertain you for questions. And on behalf of the college, I thank you so much.
Well, thank you very much. Bye-bye.